Hi, everybody. Welcome back to Stop.Sit.Surrogate with Kennedy and Ellen.
Hi, everyone.
We are here with an amazing guest today to hopefully answer any IVF questions that we have. So I'm going to let you introduce yourself.
I'm Dr. Julian Escobar. I'm a fertility physician, which is the long name for us is REI, Reproductive Endocrinology and Infertility trained person, and it's a subspecialty of OBGYN. So we are like your gynecologist that subspecializes in fertility.
Wow. How long have you been doing that?
Yeah.
I've since 2008. So what's that? 15 years?
Yeah.
Sometime.
How fun.
So
yes, it's a long road, but it's so worthwhile.
Right? And what a difference from 2008 to 2023, how IVF goes, right?
It's a completely different monster. It's completely different. I mean, how I started practicing and how I practice now. So it's been kind of cool to ride a wave, to try new things, to you have to keep up. And you know, and it's not just the medicine, but also how society has changed, the legal system has changed, and surrogacy is probably more legal, more of a legal social big deal that I think that a medical, you know, I mean, that I think it's the biggest burden. And so it's been awesome, and I've since then built my family through surrogacy, and with that came along probably just people that come from all over just the DFW, Texas, other states, but just all over the world. And it's surrogacy is the one thing that we can offer here in the US, and for a very long time Texas. There's a lot of things that people think about Texas, but Texas had very good surrogacy laws for a long time. So a lot of people, even from California, definitely from New York, came here for that. So
Dr. Escobar, awesome. You're practicing in Texas? Is that where you're at? Okay.
Yes.
Thank you. Yeah.
In the Dallas area, North Texas.
Okay. We're both out in California, and I did surrogacy. I started in 2001. And I was with the Dr. Sahikian. I don't know if you're aware of him. Yeah.
Yes.
Yeah. And so just real quick backstory on me. He put 4 eggs in with one surrogacy, one try, and we got pregnant with triplets. Right? But there was nothing.
That's a sin. That's a sin. You know.
Back then it wasn't. In 2001 it wasn't. It was like, let's just put a bunch in and see what takes. And now I know it's like one and done usually. But yeah, it's changed so much. So much.
It's changed so much. And I think, like you said, IVF has changed a lot for the better. Before, we were always transferring 2 embryos in general, just because IVF kind of sucked. And so you put 2 for the hope of 1, sometimes 0, sometimes 2, sometimes 3, but it was really like that. And then especially that the technologies in the lab, being able to grow the embryos, not just to 3 days, but 5 days. There were more biologically competent embryos, and then being able to test them genetically significantly increased the pregnancy rate. And so it took obviously a few years to realize that that practice of transferring 2 was not warranted anymore, because you were just giving people twins as opposed to a healthy just 1 baby. And so the question is, are you causing more harm than good? And in 2017, the ASRM, the American Society of Reproductive Medicine, passed a guideline that we should just be transferring 1 embryo, that it's euploid, meaning normal chromosomally tested embryo, or an embryo coming from a woman who's under 37 years of age, of eggs from a woman under 37, regardless of the age of the person carrying. And the reason is because if you compare 2 singleton pregnancies versus 1 pregnancy with twins, the chance of fetal death is 400% higher when you have twins. And I don't even know for triplets, but the chance of complications in pregnancy are 600-fold.
Wow.
People think of you guys as this amazing, you are these amazing ladies, and you have this amazing superpower, but there's also limits. And so I think it took a while for that to translate into the surrogacy world. But now there's an official recommendation to just transfer one into gestational carriers. And I'll tell you from my own personal experience, my surrogate had 3 kids of her own, full-term vaginal deliveries, carried for a woman with cardiomyopathy, twins, and delivered at 35 weeks. Then or 34 weeks, then she carried for us twins, 35 weeks delivery. And friends of mine, they said, I want to do the same thing you guys did. Put 2 embryos, got pregnant with 2. The lady had carried twins full-term for herself, but when she carried theirs, delivered at 31 weeks. So even with surrogates, I've seen problems. I had a lady that got pregnant with triplets. This woman had African lady, had tried for years. She had all these issues. The world was against her. Last resort, donor egg surrogacy, and we transferred 2 embryos, and the surrogate got pregnant with 3. She fell to the floor. It was God's miracle. She wanted just 1 baby, got 3, but the surrogate lost the pregnancy at 17 weeks. So I've seen. I know if a friend of mine said, I've known him from college. Hey, I want to do the same thing you did. He flew from Florida. We found the surrogate he wanted. He wanted someone who spoke Spanish. He wanted the kid to learn Spanish in utero. That was important to him.
Cute.
So he found the right person, and we put 2 embryos. She got pregnant with 2, and she lost the babies very early on. So obviously there's success stories like mine, but still people would question success when you deliver at 35 weeks. And I have insurance that covered the bills. The kids were not sick. They just needed to mature, but the bills were $130,000. And so you can imagine when we have people coming from all over the world to the US to do surrogacy because it's not possible, illegal in their countries.
Right.
It wouldn't be right to who pays for that. You know what I mean? And so it's multi-layers. And now the gestational carers, the surrogates have become really savvy. And I want to say I had first a push from the surrogates to transfer 1, then the standards within the American Society of Reproductive Medicine. And the reason is like you guys are a great example. Some people are just amazing. They're made for this, and they want to do it more than once or want to have the option. And the more C-sections you have, the more difficult it is to do that. Well, vaginal deliveries make it easier. They've learned that when you have twins, very often ends up with C-section, like my surrogate. She delivered her own vaginal at term, and the twins she delivered preterm via C-section. So
interesting.
Why do you think that is? If they have a C-section, it makes it more complicated.
To have another baby?
Yeah.
Oh.
Because I assume you guys have had vaginal deliveries. I don't know your person.
2 C-sections, triplets and twins. Yes. So I know what you're talking about. Yeah.
So a vaginal delivery, as you guys know, people deliver, especially after number 1, and women are just ridiculously amazing. I still don't know how you guys can push that kid and order the guy around and get up and do your thing and take care of the baby and breastfeed and just like all that stuff.
Oh my God.
And you keep going. But when you have a C-section, it kind of gets normalized because so many people have had C-sections. It's a huge abdominal surgery, and there are going to be more complications. And there's obviously people are smart and they can make their own decisions, but there's a little bit of the ethical dilemma that C-sections can lead to more complications like postpartum hemorrhage, to lose your uterus, longer hospitalization, and you're putting someone who is not benefiting herself, like biologically, you're benefiting someone else, maybe emotionally and financially you're getting a benefit, but then also you don't want put people that just may not understand the risks in that situation as a physician, and so there's not a standard, there's not a clear cut of when you should stop, like it's not like women, like I used I trained at Northwestern in Chicago. I used to work in Evanston. There's a huge community of Orthodox Jewish people, and they have lots of babies. And once someone has a C-section, has 2, 3, 4, it starts getting very hairy. They're very dangerous, can be those pregnancies, and things can just happen very fast. So you can imagine that if you have a surrogate that already comes with 1 C-section, maybe you have or 2 C-sections, then she may not be able to do this more than once. And if they have vaginal deliveries and they, like mine, they had a C-section, after 2 C-sections, a lot of people just won't work with them.
Right.
I'm not saying that that's right. I don't think you can standardize things like that. Some people with 1 C-section could have had enough damage. And then there's people that maybe have multiple C-sections. And so, but there's risk benefit. If your patient already comes pregnant, there's nothing you can do. But if you're intentionally getting someone pregnant, people start putting,
No, that makes sense, because we've had people come on and say like, oh, we got turned away because we had this many C-sections and stuff like that. So it makes sense as to the logic behind it.
And just from a very simple delivery, when you have a baby vaginally, it's okay to lose 500 cc's of blood. That's half a liter.
Okay.
When you do a C-section, about a liter. So just from blood loss, you're expected to do that. Recovery, vaginal delivery, you can go home the next day. C-sections, 3 to 4 days.
Right.
It's complications obviously can be a little bit higher. Yes, most people do fine, but I cannot see someone just using a surrogate who's had 3 C-sections or more as a surrogate. I mean, I think it just gets tough at that point.
No, that's yeah.
So
But what I want to clarify is it's not necessarily because there's lower pregnancy rates. Okay, it's not like it's more like the risk to her, to herself.
Exactly.
Yeah.
Exactly. And then
It's for the
possibly
safety.
a risk to the baby she's carrying if she goes preterm. I mean, there's all kinds of complications that can happen with a preterm pregnancy.
Yes.
The NICU, babies, all kinds of stuff. We won't even.
And also it depends. Like I talk to intended parents, IPs, all the time. Well, also like you're in Texas, for example, you want to transfer too. Well, where does your surrogate live? If she lives in the middle of nowhere, like a lot of these beautiful ladies, after all this, do you really want her to end up with premature babies in a hospital that cannot take care of your kids?
Right.
No. So then, like, if you're gonna do it right. Like my surrogate, I said, look, my only condition I have is you need to deliver at a place with a great NICU. I don't really care about anything else. Like something happens to you or the baby, I want you guys to be taken care of. So that will be a factor. I think how the more the gestational care the surrogate wants to be all natural, less medicine, more hands off, the more you should keep it nice and simple and do just 1 embryo.
Okay. Yeah.
That helped explain it, because I was like,
hey,
why just 1? Because and then what they do on twins, what a lot of surrogate agencies and IVF docs are doing is tandem surrogacies. You have two surrogates that are pregnant, hopefully at the same time, with 1 embryo each. We've heard that happen a lot. Yeah, I'm like, that's interesting.
Those are very wealthy intended parents.
Yeah,
most people cannot afford 1 surrogate in their lifetime. To do it at the same time, but I'll tell you, I have a beautiful story. This just happened last year, and this is like on my feed on Instagram. But this lady had done 7 embryo transfers. She's a gorgeous couple. 7 embryo transfers, no baby. She has some losses and not getting pregnant. She came to me after having done IVF at 2 different centers and said, I want to do surrogacy. And she had matched independently with this lady that had carried with me for her cousin. So her cousin had uterine cancer, got the uterus removed, and she carried. And so I retrieved the cousin, made embryos, and she carried for her cousin. So then she kind of independently matched with this other lady. She kind of went through and liked it out. She wanted to do for someone else who had this horrible history of not getting pregnant after 2 IVF cycles and 7 embryo transfers. So when she came to see me, she said, hey, I want to use so-and-so. Would you do, and whatever. It's like, okay, fine, that's fine. But I said, like, do you mind if I look at your history of what's been done? And I was like, there's one test you didn't get done. Do you mind doing it? You know, just in case. And we did it. And long story short, it was positive. I said, do you want me to try to transfer you, even though you have this surrogate? And she said, well, okay. But she basically, she was just down to the ground, like she didn't expect anything.
Oh,
So I got to transfer her before the surrogate. The surrogate was 6 weeks later, and both got pregnant and both delivered at the end of last year. They were like 6 weeks apart.
oh my gosh. That's awesome.
Yes, it was
That's
an
awesome.
incredible story. And it took her forever to own it. It's like she knew there was impending doom. She knew she was going to lose this pregnancy, and it just never happened. And so
good
it was
for
great.
her. Oh, that's awesome.
Yes.
That's amazing. It always happens when you least expect it too. Always.
Yes. And so, yeah, and you know, and like I, for example, transferred 2 embryos because we both wanted to have biological children. I have a male partner, and we put a boy and a girl when people didn't really do genetic testing back then. But I was like, I'm a fertility doctor. He's a 21-year-old donor, but I want to make sure I look at this lady and tell her I've done everything I could do to give you the best chances and healthiest pregnancy. And so we put a boy and a girl with the thought that we were probably just going to get pregnant with one. And the only way for us to know biologically who was the parent in case we could do another journey was to know the gender. So we didn't really do the gender because we cared about the gender. We just wanted to have the option of doing 2 journeys if we could.
Yeah.
So I get it. You know, it's a big thing.
That's
how
awesome.
old are your twins?
They are 8.
Oh,
I'll show you.
How amazing.
Look how, oh God, they're gorgeous.
Oh my gosh.
Yes.
Oh my gosh. And like they look alike.
Like each other.
Yeah.
No, it's been awesome. Thanks to you guys. And they know our surrogate Molly, and during Corona, it wasn't easy to see her, but we see each other probably once a year, text multiple times, and they know their entire story. Someone sent me a book that they wrote about surrogacy, and it talks about cookies and the oven and chicken eggs and all that stuff. And you should have seen my kids going through it. It's like, how come there's an oven there? You know, like what are you talking about? Cookies. It's like, for them, it's just very simple. You know, you need eggs, not just sperm. And you need a uterus, and my parents don't have that, and that's what they needed to do. And thank God that we're here because of team effort. You know, they know it's not their mom, but it's kind of like a role that their classmates, their moms carried. You know, like they kind of start. You know, they get it. You know, and I think it's just amazing, and also going through the journey and getting to know her children and her family was awesome. And I always said to my patients, I said, like, who cares who referred you, what surrogacy agency, what doctor? You need to do your own job. I mean, it's like you need to talk for 5 minutes to someone to know if you like them or not. How can you not? How this person is going to be part of your life and is going to take care of your child. How can you not get to know this person? You know, and I think people just miss out when they don't do that. And I know sometimes it's difficult. Like if you care for someone in China and they're the opposite end of the day and they speak a different language, I get it. You know, and culturally they're so different. But I do think that you need to do your part to get to know each other. And I met my surrogate for brunch and her husband, you know, and in the end we were like in love with each other. And so I think people do need to, like, it didn't matter if I was a physician, it's still the same journey, like still all the emotions, didn't matter she had carried before, you know, this is a big deal. And it's just really nice when you know the other person as a person. And so getting to know her family and her kids, and they used to call us the owners. Oh, Mom, when are we going to see the owners? You know?
I love it.
That's so cute. Oh
yeah, we were the owners, and and they thought it was so normal to carry for someone else. So like if they saw a woman pregnant, they'll say, "Oh, is that yours?" You know, and so
Oh God.
which
Yeah.
normal kids would never ask that. But you know, so my point is that I do think kids are very pragmatic, black or white. They get it. We make a big deal in our brains.
Totally.
My children understood things very well. Her children understood things very well. When they're mature, they're older, they realize their mom was a very special person that did this for other people, that this is not something that everyone does. And I do think people have fun with it. You know, her husband had lots of fun at church saying, "Oh, it's not mine." You know,
I
it's not
know,
mine.
I know, right? Love it. Yep.
Oh
yep.
my gosh.
We had fun with ours too when people would ask. No, they're not ours. What?
Like, what?
Yeah, it's a fun shocker.
Go over there and do your thing. Yeah.
Yeah, so it's good. So it's so again, all these things are very medical. Like today I had a meeting with 3 attorneys that is what they do. And it's changed so much since I did it, you know, and in many ways the world has gone back, you know, has gotten more difficult. So like when I did it, we couldn't even get married. And so we had to fly to California to get married right before the kids were born, just to protect the children, you know.
Did you do a pre-birth judgment, or did you do a pre-birth judgment to get both names on the birth certificate? Or did you go and do it?
Yes, and when we got it done, you're gonna kill me, but it's again,
okay.
when you do it for yourself, it's all emotional. We were a success for our attorney who's extremely busy, because we were the first case in this part of the country where we didn't have to do anything after the kids were born. Like we had the pre-birth
judgment.
Awesome. You know more about this, you know, than I do, and so it was seamless. You know, it was fairly easy. But now they're
that way. It should be that way, right? But people make it difficult. Yeah.
But what they were telling me today is that at least in Texas now, if the couple is not married, they're having a huge issue with surrogacy. And so they're having to.
Is it married? The intended parents or the surrogate?
The intended parents.
Okay,
the intended parents. And there's many reasons why people cannot do surrogacy. Like, for example, if your surrogate lives in Mexico, you cannot do it because Mexican law doesn't protect the contract you've signed in California or in Texas, you know? And so that's her baby, not your baby. And, you know, it's bad both ways. But also they were saying that if the intended parent, let's say the sperm and the egg are from donors and not from her, it may, at least in Texas now, it may just not, I don't know how this applies to the states, may not be valid, meaning it's the surrogate's baby, like basically, which is scary. Yes, I had never heard of that, and today that's something that wasn't there before.
So the intended parents would essentially have to adopt this baby? Technically?
I don't know if they have to do that, but if the surrogate fell in love with the pregnancy and everything, she could just walk out with a child, probably.
Well, that's scary. That's very
scary.
You're right. It is going back. Wow.
So my point is that it doesn't matter how much you guys have done this and I've done this.
Yeah.
The medicine has gotten better, but the law has all these changes, you know, like people like me couldn't get married before, and now they can. And I do think that opened up for a lot of people to even think of having a family, right? Like if you cannot even be recognized as a couple, it's very difficult to think that you're going to buy a home, have a security system, you know, and be accepted by society or your church or your community. So how can you have babies, you know? And so, but as that has changed, a lot of people are moving towards having kids, you know? And so in some ways it's kind of, and so then you're like, oh my God, now I see other people. It's not just Ricky Martin that has children, you know? And so, but in other ways, it's also gone backwards, you know? And so, it's the law is just very interesting, as you know.
Yeah, it is. I'm going to change just a little bit, because I'm actually kind of interested because you even started this. I just saw you're now starting like an IVF like introduction, right? On your
Yes.
Instagram.
Yes.
Okay. Maybe I'm naive, but like I mean, they just tell me to take the medicine and I'm like, I'll take the medicine. So like, can you explain like why certain things are needed? Like people take estrogen, right? And that's to help you like ovulate in a sense, even though you're a surrogate, right? Or am I wrong?
I'll explain.
Okay.
You carry the babies. I explain that part.
Okay.
So let me break it down. A normal menstrual cycle. So when you bleed, it means you didn't get pregnant, and everything is at 0. So your estrogen is low, and then the brain senses that as it needs to release hormone to grow an egg. As the egg grows, that follicle where the egg is growing produces estrogen. Estrogen thickens your lining. So your lining goes from having been shed and being 3 millimeters on sonogram to maybe 8 to 11 on sonogram mid-cycle.
Okay.
Also, the morphology changes, meaning as it gets prettier, it has 3 lines, kind of like this. The line out here, the line in the middle, and the line up here. So as a surrogate, just memorize 8 millimeters trilaminar is your gold standard. Perfect. It doesn't mean that you cannot do it if you cannot attain that, but that is kind of what people are looking at. And so in theory, if you expose a normal woman, which a surrogate should be the most normal textbook, right? You scan her mid-cycle and a natural cycle, or you give her estrogen for about 2 weeks, which is normally you grow an egg for 2 weeks, then you ovulate and you have 2 weeks of progesterone. If you don't get pregnant, you bleed. And so it's 2 weeks, 2 weeks, that's 28 days. And so that's why the birth control pill is 28 days. It just emulates that. And so what we want to do on a cycle is in 2 weeks, give the surrogate enough estrogen so that the estrogen level is between 150 and 300. And that is kind of a normal cycle. And with that, you should be able to grow a lining. So sometimes if the surrogate is 250 pounds, will be different if she's 100 pounds, right? She may need a little bit more estrogen. And in Texas or in California, maybe if you use patches as opposed to pills as a physician, and that's what you give your patients, well, guess what? If she likes to swim a lot or she sweats a lot, she may not absorb as much estrogen. The patches have a delivery system. Not all brands are going to be the same. So you will see a lot of fluctuations on how people absorb that estrogen. And so it's not a one size fits all per se. And then same thing with the pills are easier because they're easily to ingest and more absorb, but people are different sizes. And so I do think that a mixture of the amount of estrogen you give someone, routes amount over time should give you that 8 millimeters in trilaminar. And so sometimes it is that 2 weeks wasn't enough, that she needs 2.5 or 3 weeks. Sometimes you just need to up the estrogen, and that's going to start. But the opposite is true also. I had a surrogate from Oklahoma, had the most glowing recommendation from the prior fertility doctor. She'd been transferred 3 times. She never got pregnant. When she came to see me to transfer for someone else, and then I scanned her, and right in the first visit, I was like, your lining is 19. I was like, this is just too thick. Normally, the lining is like money. The higher, the better. But there's an upper limit. You know, it's like, it starts being like pathologic. Like there's nothing necessarily wrong, but I don't see that. As soon as I put fluid, she had like 50 polyps inside. So I'm like, that's why she didn't conceive before. Now, most other places would have rejected her on the spot because she failed so many times. But this is something that is easily to fix, you know, and she has insurance. For her own sake, she should be getting rid of these polyps, you know. But that's not necessarily what we see all the time. But if you have polyps, lining takes to be thick, easily fixable. If you have a thin lining, that is the problem. You know, a thin lining, you can give estrogen, higher doses of estrogen. You can always see if the levels are high. So if someone comes with a thin lining and her estrogen is 100, I'm like, estradiol, that's the actual type of estrogen we measure. Then I'm like, well, she just didn't get enough estrogen. She needs more estrogen, you know? And so you can be logical about it. It's not that I would just give someone a certain amount of estrogen for some time and label her because her lining is just 6, you know, then you have to kind of put it together. You know, how did she take it? How often did she follow the instructions? Is her estrogen high enough? And so I tend to practice before the real deal, you know, have a little one practice run before we move into the actual cycle, especially if they've never carried as a surrogate before.
Okay.
If they've carried, it's important to get those records to have an accurate expectation. And even though we all have our favorite recipe, if something's worked well for someone before, I'll trade my recipe for the recipe they used before.
Oh, okay. Now, you were saying, you know, because it's not one size fits all and everybody's bodies are different and their weight is different. Is that why fertility clinics also ask for BMIs or?
Yeah, I think for other reasons, yes, you're right. So I mean, overall, there are lower pregnancy rates the bigger the woman gets. And so, and I want to say that for normal weight and the next layer, there are the same pregnancy rates, but I want to say after your BMI goes above 30, it starts dropping. So pregnancy rates, I'm not saying surrogates, in general patients with IVF, for every 5 points of BMI increase of 30 to 35, you get a 5% decrease in pregnancy rates.
Okay.
So now, I think we're trying to tease everything out. So for example, my surrogate, she was like a German pear, you know, so, but she's in great health. That's just how God made her. Like her thyroid was normal. She was not pre-diabetic. That's who she is. And so I was fine with that. And I know in California, people would have had a very tough time with her, you know? So again, you may not be able to fit everything. I had a fertility doctor come and give a lecture here from Beverly Hills. And he said, oh yeah, we don't take care of any patients with a BMI over 35. And we're like, we'd have no patients. We're in Texas, you know, like people here are larger. So
that's right. They do knock you out. If that's on the application, what's your BMI? And they just knock you out if you're over. I don't know what the criteria is. I don't know what the level is now, but you're right. They knock you out. You're done.
And even the patients, you know, because people depend so much on rate. Sometimes they go obsessed and trying to cherry pick their patients. But, you know, I mean, I don't do that. I mean, of course you have to be smart, but my purpose is not going to be my rates, you know, my purpose is going to be doing the right thing for everyone, you know? And so, so I do think that you could work with someone who has a little bit larger BMI if she's been super healthy, she doesn't have prediabetes, if her thyroid is fine, if she didn't have gestational diabetes in her prior pregnancies, all of those things.
Okay. You were mentioning also patches. I've never heard of a patch, but like I've heard of like orals and vaginal inserts, which everyone hates those. Those are like the worst. In your professional opinion, do you really think that there's like a big difference in the way that you take the medication?
I think, I mean, I want to say that years ago, we were doing 4 patches at a time, and then we realized all these issues with absorption, and it was not very reliable. And so now we switched to having 1 patch and 2 pills. Same thing for progesterone. Sorry, 3 pills for progesterone. We also give it 2 different routes, intramuscular and vaginally. I just think because of people are so different, for us, having 2 routes kind of covers you up a little bit. If you screw up one, you have the other one there. You don't have to do that. So for example, for all my patients and my surrogates, I use intramuscular progesterone because in all studies it's shown to have the highest pregnancy rates. Okay. And so that's why we do it, and less bleeding. Okay. Having said that, vaginal is a second close.
Okay.
And then oral progesterone just absolutely sucks in IVF. Okay. It just completely now in a natural pregnancy or ovulation induction is different, but for something like this, no. So it just gets degraded by the liver before it goes throughout your body. And so it's just not very reliable. And so, but for my own surrogate, she had done before vaginal years ago, and she done fine. So even for my own, I was fine.
Yeah.
So I do think you have to use your brain a little bit. You know what I mean? Again, it can just be so cookie cutter, and she did amazing, you know? And so.
Interesting.
So yeah, there's oral medications that, well, way back in the day, I did Lupron to suppress my system.
Yes.
Do you still do Lupron now? Is that a thing?
Yes. So let me walk people through it. You're absolutely right. That's a very good point. So my cycle is a very classic cycle, but it can be done so many different ways. And so you get a period, you start birth control pills. Why? Because birth control pills are estrogen and progesterone. And when your brain senses estrogen and progesterone, it decreases the amount of hormone it secretes to stimulate your ovaries, because it says, oh, the ovaries must be working. I'm seeing these hormones. We want the surrogate to have very quiet ovaries for two reasons. We don't want her hormones to screw up what we're doing. Two, we don't want her to get pregnant with her baby and give it up, thinking that it was the baby that she got transferred, which has happened. And so, yeah. And so there's those two things. So we start birth control pills because it keeps everything quiet. And then we transition into Lupron. It's a tiny little dose like Botox. And what it does is it really suppresses your brain. And so that way the brain is not releasing anything, and then you can stop the birth control pill. So the birth control pill is like a bridge between you getting your cycle and starting Lupron. Once you start Lupron, you stop the birth control pill, you bleed, and your brain is just quiet. FSH and LH coming from the pituitary are very low. Okay. So then everything is kind of baseline, kind of like a white canvas. And so then we build your lining with estrogen. And like I said before, it takes about 2 weeks.
Right.
And really the only ways that we give it are the patch and by mouth. When people have a really tough time growing their lining that shouldn't be a gestational carrier, we give it also vaginally. Okay. And if sometimes there's tough situations, again, these are more for people who are trying to conceive themselves. For their own, we give them aspirin because we think it increases blood flow to the uterus and therefore allows the lining to grow. And sometimes vitamin E. Okay. And so those are kind of tricks to make her. Now, if a patient has had abortions or terminations or had a lot of bleeding postpartum, instrumentation of the uterus around pregnancy can cause scar tissue. And I would say that's the number one cause for us to see a thin lining or not pretty lining. Okay. And that it can be tough to fix, to be honest. Very simple, small surgery, but it takes normally multiple rounds of that. And a lot of people who have had aggressive procedures like that end up needing a gestational carrier to carry for them. Okay. So that would be number one in my differential. If I see someone, whether it's a gestational carrier or not, who has a thin lining, like I gave her estrogen for 2 or 3 weeks, the estrogen levels were high and the lining still thin, it's like, does she have scar tissue? Okay. So once you've grown your lining, we just want to make sure you're not ovulating, that your ovaries are still quiet, so that when we start progesterone, and progesterone is pro-gestational, pro-pregnancy, is the hormone of pregnancy that keeps you pregnant because you're not ovulating yourself. Therefore, we need to fool your uterus, your endometrium, as if you had just ovulated, because progesterone primes the endometrium, meaning it starts creating molecular changes where different genes get expressed, so that proteins get expressed that accept that embryo and allows the embryo to implant. And we need to synchronize that development of the endometrium with the biological development of the embryo. So a 3-day-old embryo is gonna need less hours of priming than a 5-day-old embryo. Many embryos are 6 or 7 days old, but biologically they look like a 5-day-old embryo, so we treat them as 5. Okay. So that's what we're trying to do, to just kind of fool the lining. And at that point, the lining shrinks and becomes kind of more white, and that trilaminar appearance starts going away. And that's when we do the embryo transfer at that point. So something you guys may have heard is the ERA, or endometrial receptivity assay, which the premise is, if you put someone through everything we just mentioned, but at the moment of an embryo transfer, we don't transfer, we just biopsy a little bit of that lining. Yes. We can send that for testing and look at mRNA expression, basically which genes are the most active. And they can look at over 200 genes that have to do with embryonic implantation. and see if for that person, that protocol was perfect, or if we need to tweak it. So it's kind of personalized medicine. So now what we're realizing is probably not everyone needs the same type of regimen. And these are very high stake pregnancies. And so I think the first revolution, like we discussed before, was genetic testing of the embryos, giving you, so for example, if the eggs are from a 35-year-old, maybe the chance of pregnancy is 40%. If she's 40, it's probably 10, 15%. But if you tested the embryos and they're normal, you get a 70% chance of pregnancy. It's not 100%.
Okay.
That 30% delta could be just the embryo wasn't meant to be. Could have been just random things that we don't understand yet. But it can also be that maybe that protocol works on most people, but not perfectly on that person, you know? And so this ERA allows us to test people like as a dry run, as a dress rehearsal before you move on to practice with an actual embryo. And so it depends on the situation. So if a surrogate got an embryo transferred and she didn't conceive, that's something you could do before you transfer again. Or if the intended parents only have 1 or 2 embryos and they just want to make sure everything is done ahead, it can be discussed. So I'm not saying this is something that everyone should do, but especially if someone has not gotten pregnant via IVF, that, as you guys know, is very different than having intercourse. These are things that can be done to control all the variables.
Great.
Interesting.
Really, that's really nice.
Like, yeah, that's like crazy informative.
When I was
Now, I'll tell you something then. So here it goes. So you guys know that everyone has progesterone and oil, and vaginal progesterone also people don't really like.
Sorry.
But I would say that if a surrogate were to go to a clinic where they just love doing, let's say, progesterone and oil, that's the only thing they did.
Okay.
But she just kind of had an aversion towards that, and she was okay with vaginal. I think it would be reasonable to do a practice run an ERA cycle with vaginal, you know, and if you get a result that says, yes, 129 hours of progesterone are perfect for Mary, then you do that, you know, or like I did. If my surrogate had tried that before and that worked for her, I just copy paste the same recipe. And so I do think there's different ways of doing it.
Yeah. Now, something that I see a lot of surrogates, like, you know, reaching out to other people, like when it's before transfer time and it's like, I'm not thick enough. How do I thicken myself? Like, after, you know, with the meds, do you have any tips for anybody? Or is it just like, no, the medicine's going to do its thing? Yeah.
I think just one, make sure you're doing your medications correctly, you know, because that can be something. Second, I ask all my surrogates that are monitored elsewhere, which is many of them, to take a picture of the image of their lining, because many times it's just probably not done correctly. And so there's nothing like sending a picture like that to the nurse that is managing you or something via email. I mean, everyone has a cell phone that can take a picture, you know? And when I see that, it gives me peace of mind. I see, they called it non-trilaminar. I can see it's trilaminar. Or they put the calipers a certain way. I would probably give it like that. And so I think that's if it's not measured correctly, you can get that you want to just exclude all those things first. I think just baby, like I said, baby aspirin sometimes, but I'm not sure that really helps. I just think that a normal surrogate shouldn't have a very difficult time reaching minimal milestones. Now, 8 is ingrained in our brains, but because it comes from the time of fresh embryo transfers, when we got the eggs out of the woman and transferring to the same woman during the same cycle.
Okay.
But for frozen embryo transfers, which is what every single surrogate is going to do, meaning it's a program cycle, we are seeing that 7 millimeters or above, especially if trilaminar, gives you exactly the same pregnancy rates.
Okay.
So one thing is for me,
7 to what? Like, would you want to go over what? 7 to 9?
The upper limit is not is really less clear, but I would say I would get concerned after 14 or 15. Like, I just would want to make sure that there's not a polyp. But if I test that there's no polyps, I don't really care. It's perfect, you know. You just don't want to miss that. And at the same time, if the lining is not too thick, you know, you kind of want to work it out a bit, you know, like you just don't want to dispose of people after people have spent so many months working on these things, like it's an object, you know what I mean? And so you really need to just work with people and try to figure it out, you know. So
Totally.
Interesting. Yeah. So there's nothing, there's no foods, it's all medication, really.
All that.
yeah, so some people say that having sex as
I
you
do
get
hear that.
closer, yeah, and I don't think there's anything wrong, especially if you I mean, you think it's blood flow. It's what happens in nature. If nature develops something out of millions of years, something there works, you know. And so I think that's something that they can consider. I would say if someone is a marathon runner, I would probably just kind of not compromise all the blood flow to the uterus, to just go to your heart, you know. Like, it's just minimal things. But I frankly don't see that issue too often with gestational carriers.
While we're on the thing of what I see people posting about, a lot of the times, I'm sure that you have people maybe that come in too when they do the intramuscular shots in the back and they develop the giant scar tissue balls. You know, people are, the only thing that have ever been told to us is, you know, ice and heat. And I'm sure that is that something that you would also say, just ice and heat?
Yeah, I mean, I would say, well, first of all, they sell now like products that you can put to lower the pain. Some surrogates are very practical. They're like, I don't need that. It's just easier to inject myself and go. And so I would use something for pain, but you know, you guys are tough, very tough people. So and then what I would say is you just trade places. Warming up that oil will make it more fluid and probably just get more out of that place. So kind of warm up the oil in your fist or put it, you know, in your body temperature. And then I think just letting it flow, just putting maybe some heat after that, just allowing the body to just absorb all of it, bring more blood flow to suck it out. But if you go and put like if you put ice in there so you don't feel it and you numb it, you're going to make it harder to inject, and there's not going to be blood flow to absorb all that. So it's going to stick there more.
Okay.
It's an awful drug. It's awful.
Okay.
There's no way around it, you
Yeah,
know.
no. There isn't.
But you know, people do it. I think it's just a mental, it's a mental thing, but you cannot sweet talk people into it, you know. So
yeah.
I used to put, when I give myself my own injections, I used to put a piece of chocolate in my mouth. And when I would give myself the injection, it was like, it was a reward thing. Like, hey, I'm going to get chocolate. Like, I knew I was getting this huge shot, but I was trying to trick myself.
Sure.
You have to, you have to do something, because you cannot glorify it, you know. It is.
It is what it is. Oh, with your protocol, because we hear so many different things for post-transfer. So like, do you put your surrogates or your patients on bed rest? Are they not on bed rest? Like, it's wild to see the variations.
Yes, I care more about my patients being in a semi-bed rest than the surrogates. Because for me, it's more of a psychological issue.
Sure.
These women have suffered so much that then they finally get to that embryo transfer, and then let's say they have a cough attack. They'll think 4 or 5 days later, when they're waiting for that beta that is not coming sooner, oh my God, did I lose my baby because I coughed too much, or I had a bowel movement, or I walked to the kitchen, you know? So sometimes I'm like, look, you just need 2 days where you don't care about anything in life. It's just about you. And you don't have to be in bed, but in a couch, in a chair. I just wanted to relax.
Okay.
And it's more for psychological reasons than because I think it helps. And for the surrogates, many are just very busy mommies, you know? And I do think I want them, if they're coming from afar, to maybe take a day or 2 days off in a hotel, you know, go to a restaurant, just be chill, you know. But I do think the psychological aspect is much less or none there. I think they're very just practical, and they know that it's illogical to think because you did something normal in your daily life that you're gonna get pregnant because of that.
Right. And to piggyback on that, you know, there's when a surrogate has a miscarriage, or they don't come back with, you know, the positive betas, you know, I mean, it's nothing that they necessarily did. If they took all their meds and everything, it just didn't take, right?
Yeah, I mean, I really think it's you just have to have your own conscience, you know, and you have to realize that when yeah, I mean, people who has the most kids in this world? I mean, look in just the countryside in Mexico or China or all these places like 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 the people who work the hardest have the most kids, and so but there's a lot of effort and expense going into these pregnancies. So I think you just want to be respectful and do just normal things, no more, no less. I would not have sex, not because there's anything that says that something bad is going to happen, but you just want to have that thing. You know what? I tried, I did my best. And I think it's just being nothing like your own conscience. And the rest is other people's responsibility. You did your job, you know, it's on them, it's on the embryos, on the clinic.
Yeah.
I do think it's important not to start a blaming game. I don't like, you know, the intended parents shouldn't be blaming the surrogate or the clinic. The clinic shouldn't be throwing the surrogate or the embryo under the bus. I just don't think that's gets anyone where they need to be. I do think it's unrealistic to think that people get pregnant all the time. My own surrogate, like I said, had 3 boys herself, transferred 2 embryos, got twins, got my 2 embryos, got twins. So 100% success rate on the transfers. We transferred 1 more time. She got pregnant. The baby didn't develop, but the pregnancy was there. There was just no baby. There was a placenta, no baby, and so not her fault. But then we just kind of, you know, that was hard, very hard for us. So we moved on and just focused on the twins. And so she tried to carry 3 times after that. Huge practice in the East Coast, and was not successful. And it's like, okay, here you have someone who's at 100% rate, 4 embryos transferred, and now nothing. So she came to me and said, hey, Dr. Escobar or Julian, you know, do you mind taking care of me for me to carry for these guys that live in Spain who made embryos 2 years ago in Houston, and they haven't been able to find a surrogate. And so we matched. And I said, well, Molly, I adore you. You're the most amazing person on the planet, but you just failed 3 times, you know, like, so I said, you just have to go through everything that I would put anyone through in your case. And she was fine with it. We did all the testing. So like, it didn't matter what I thought of her and what I knew of her. And I had it so concrete, more than anyone else you could ask for records. But I'm like, I just have to show myself and the intended parents and you that we do all of these things to make sure that everything is fine. And she did, and I transferred her, and she got pregnant and had the baby, you know. So I do think that
Interesting.
she was an advocate for herself, you know, and she gave them multiple tries, but in the end, there's what works for her, you know. And so yeah, I mean, I think a couple times a couple of good chances is a very good thing. And you know, and as a certain, like, and I just told you the Oklahoma lady also who got transferred 3 times, and you know, that's not good to have in your history.
They ding us. They ding us.
Yes, and she was full of polyps. That's a mistake from the clinic, you know. So I wouldn't be afraid of getting tested. You know, you want to be put in the best possible situation. I also tend to do an HSG. If you have dilated tubes, it reduces the chance of pregnancy by 50 to 75%. And so, which you could totally have. And so I mean, I think people need to be worked up, and frankly, I get all the testing in one day done. When I have people coming from outside of DFW, we talk like this over video, and then we plan a day for her to come, and I do everything one day, and they go back, you know, and they can do all this stuff there. I want them to build that relationship with their OBGYN, because that way is a handoff, you know, and if they don't have one, to find one, so that person says, okay, she's good to go. And that way I'm like, you're gonna be seeing her as soon as I get her pregnant, and we already have a working relationship, you know. But I don't think any of these things are to be judgmental, but you just want to make sure when things go right, no one really cares. But when they don't go right, everyone starts going back, and you don't have to do everything at once, but you want to make sure at least you thought about it, you know. And And if it didn't, then you need to have a second layer of things to do. But if the doctor is like, oh, we're just going to do the same, and there's a lot of things that haven't been done,
Right.
then things don't look good for the clinic, for the intended parents, and for the surrogate when you've had two misses on a surrogate.
Right.
Yeah. No, absolutely.
Do you have, I'm just curious, do you have a percentage of, for surrogates, gestational surrogates, a percentage of pregnancy rate? Like when you do first time transfers, is it a 70% rate, 50%?
No, I think it's around a 70%. I think it's around a 70%.
Good.
I think it's around a 70%.
Really good.
And there's always exceptions, right? I mean,
Yeah,
there's one person, she was the sweetest person in the world. And, just because someone had an easy time getting pregnant 10 years ago, things change, and, but most people are fine. And I have no problem working with someone who's older also. I'm like, I've worked with surrogates, they're 35, 40, 42, it's
no
not
50s.
their egg.
No 50s, right? I'll come to Texas. No, I'm kidding. It's all right. I'm trying to get back in the game. I'm trying to get back in and I can't.
I know. I get it.
Okay.
Oh my God. Well, just a little snip for because medical clearance, you guys do a medical clearance, right? For surrogates and even egg donors, I'm assuming. And that's just checking, is that checking lining then, or are you just checking?
Oh, I see. I frankly hate that. Okay.
Okay.
And that is imposed by the agencies and the attorneys.
Oh,
And I
okay.
think it's that continuum. Okay. It's kind of like dating, right?
Yeah.
Just because you went out with a guy and it went great, are you going to marry him? No, you're just getting started. You're just getting to know this person. So it's like, what is medical clearance? So what I can say is, I guess, up to this moment, what I know of this surrogate, she's cleared,
Yeah.
but there's more stuff coming, so, and or that even if we've done the normal evaluation, there may be something that happens, right? And so that may change things. And so I just think the medical clearance is just is in general is just the only reason people care about it is because it's a threshold to for a contract or to get paid or something, but it has no real medical meaning, because then you have to define what is medical clearance, right? So is medical clearance. So for example, for me, it would be the most important thing is your uterus, right? And so I need to make sure your uterus looks pretty and that your lining looks good. And so I want to bring you mid-cycle or give you estrogen for a couple of weeks and see how it looks. And I want to put a little bit of water, separate the walls, and make sure it's a pretty cavity and there's no abnormalities. If there's abnormalities, I don't think I would say the patient is not cleared. Like if you have a polyp, that's fine. That's not against medical clearance. That's just, I need to remove the polyp before I transfer the embryo.
Yes.
So you know what I mean? So just finding a problem, it wouldn't necessarily mean that she's not cleared.
Right.
And so then what happens? Like the FDA doesn't really have there's not a lot of things you need to do to a surrogate to clear her. Now the intended parents, where the gametes come from, the egg and the sperm and the embryo, they have to go through very rigorous. The FDA says that you have to do this. Why? Because they care about protecting the surrogate. They don't care about protecting the baby that much or the intended parents. They care about protecting the surrogate. So for the surrogate, I can do whatever I want. So an OB panel that you get done in normal pregnancy will suffice, right? But because there's so much social stuff around surrogacy, many of us tend to do a drug screen on the surrogate and her husband, if she has a partner, sexually intimate partner, and also STDs and infectious diseases on them. Do you have to? You don't have to, but is the right thing to do? It's probably the right thing to do. You know what I mean? It's just, now, let's say you find someone who had chlamydia. Does that exclude her? No. You can just treat the chlamydia, but then people need to know about it. We all need to know, she has herpes. Well, that's not a problem. It just means that if she's about to deliver and she has a lesion, she's gonna get a C-section. You know what I mean? So I that's why I'm like things cannot be put so much black or and white. Anything is all about consent and people knowing what they're doing, what their options are. And that the intended parents need to know, because it needs to be a conversation. And I do think that just like there's intended parents, like a lot of Chinese people are positive for hepatitis B. Like, I just make sure my gestational care knows that she's vaccinated for it, that she's got a titer and is immune against it. We know you cannot really pass it through IVF and putting an embryo, but we just want to make sure we go through the process.
Right.
Ooh, okay, now that clicked in my head, because some at HIV. So, because I know that they wash the sperm, right? And that takes it away. Is that what that does?
So it's let me go back. There's hundreds of cases around the world from even from serodiscordant couples. The guy's positive, the woman's negative in a marriage, you know. And with IVF, obviously you can get pregnant without no semen. It's just a sperm. So we take a single sperm and inject it into the egg. That's ICSI, intracytoplasmic sperm injection. That's how we fertilize the eggs. You need a fairly big load of HIV to get infected. And when we do these things, you're not really getting exposed. Especially these days, people get placed on these antiretrovirals, and they're undetectable. So people nowadays who have HIV, like I saw a patient today, he's HIV positive, the wife is not. They have sex, you know, and sometimes they put the wife also on PrEP to prevent that. So I think HIV has changed a lot from something that used to kill people to something that people can just have normal life and protect themselves. So obviously, if I'm telling you that in the past, when we didn't have these drugs and people have had viral loads, we could prevent HIV transmission by doing IVF with ICSI. Imagine now that people are under these drugs and in theory, there's no virus. But what we do is we go one step further. And even though we can all wash the sperm, I send my patients to, it's called SPAR program from the Bedford Foundation out of Massachusetts. And they are more comprehensive. They just don't do just sperm washing, but they have proper education for the gestational carrier. They get this 3 sperm samples from the guy and test for HIV in each sperm sample, which a clinic can't really do easily. And then they basically use samples that don't have HIV. So they've gone a step further, plus all the counseling and everything else, you know. But as far as I know, there's never been a case reported of transmission of HIV by doing any of these things. And so, so I do think I'm so happy that a lot of the stigma has gone away, and that people are okay to do it, because sometimes even if it makes sense, you may just not want to do it, you know. And to see that that is getting done, it's great. And that clinics are maybe opening up. A lot of clinics won't do it or didn't do it in the past, or keep it very hush hush, because they're afraid that if other people find out that they treat people with X, Y, or Z, that it's going to affect the perception. And you know what? I mean, at the end of the day, we're here. I became a physician to help people, and I didn't just become a physician to help people. I didn't need help, you know. And so doesn't happen very often, but there's more and more people who are living very fulfilling lives, you know, and just contracted HIV in the past, you know. So
I just learned about SPAR. So they're a great organization.
And it's expensive. I mean, the parents need to pay about $8,000 just to process the sperm, so it adds to the entire thing. It's a lot, but I feel it's even though I know that the risk to the surrogate is basically zero if I didn't use SPAR, I just feel that ethically and morally, to protect the surrogate and her family, and they know we've done everything we could do. It's something that has been done so well and it's worked so well. I just think it's the right thing to do.
And I think it also gives the surrogate a peace of mind with it too.
Which is the most important part. That's my point. It's the most important part. So I said to the intended parents from the get-go, I said, like, you're gonna have to do this because you need to work with her, and for me to reassure her and make her understand that there's no risk for her, you have to do this. You know, it's
that's great. It's amazing. Here's a fun one. Do you have transfer superstitions like McDonald's fries, like eat them afterwards? Like,
oh my, I want to eat McDonald's fries every time I do a transfer, you know, like there's nothing like McDonald's. No, whatever makes you happy, I think. Like your mom would say, chocolate, whatever it is, just no wine anymore, you know, maybe before the transfer, but not after that. I've heard people talk about pineapple, the core of the pineapple and all these things. No, I mean, I think that's just personal. I think in the end, the mind does a lot. And I think if you're happy and you're positive, that's why the placebo effect exists. It's a real effect. And I do think it helps. So I think doing things that make you feel comfortable and in control and gives you peace of mind are going to be good. I mean, people usually are happy when they're having sex. So, you know, so I think just being happy, that happy hormone, it's a positive, a good thing, whatever that is.
Yeah, I'm here for it.
Yes. I mean, McDonald's fries and chocolate. What else could you do? You know, I mean,
it's so funny. Like out of all the fries in the world, everybody's like the McDonald's fries are the ones that do it.
Well, I'll tell you. Well, I you know, like it's kind of, you know, a little bit insulting when people say some things, but it's okay. I understand. And when people say, "Oh yeah, I finally got pregnant because I did acupuncture," I'm like, "Are you kidding me? All the years we spent doing this, and you think it was the acupuncture?" I mean, but if you don't get pregnant, the acupuncturist or the chiropractor is gonna throw the doctor under the bus and say, you know, I'm like, so you get it when it's positive, but when it's negative, it's so
Oh, how fun. That's interesting. Do you recommend acupuncture? Is that like something that you like recommend to people or not so much?
I think if I do think, especially again, that the parents themselves, they need to relax. And so if the way for her to have time to center herself is acupuncture, yoga, a massage, going to church, jogging, you know, she should be doing those things because you need. I tell them, you're in like the Olympics. All these Olympians, all these professional players need a lot of support. And so you need some support. The husband is probably not there. And so I'm not saying that a surrogate couldn't do it or benefit, but I do think, you know, like you're doing this, like whatever you think is going to help you kind of have a clear mind, relax, you know, I think will be just beneficial. So
yeah, mind, body, and soul is like really what's in it.
Yeah,
I think it's super important, you know. So and that's why it's important to get to know the surrogate and her family life and her work life. For example, my surrogate said to me, well, I have 3 teenage boys. In the summer, I'm going to be driving them everywhere. Do you want me to be driving my 3 boys in Texas heat in the summer with twins? I said no. And she said, okay, so then transfer me for when my 3rd trimester is the winter. And that's what we did. So I do think you need to work to lower her stress, her anxiety, her life is important. And for me, what, you know, and so I do think, I mean, that was probably an extreme version of it, but I do think even the small, I do think these things are important, you know?
Look at that surrogate even knowing, like,
having the forethought.
That's not going to be a good thing. Yeah.
She's amazing. I love her. Molly's amazing.
Oh, that's amazing. Oh my gosh. Do you have any more questions, Mom? Like, you're so thorough.
Did we hit all the ones?
I don't know.
I think so. Oh, can you explain something? Because I'm so naive. Again, I just listen to whatever the doctors say. And I know a lot of people do too. But can you kind of explain the HCG levels a little bit? And like...
Yeah. So the embryo, when we transfer, is a little ball like this, and that is the placental side, and there's a little ball like that as the baby side. the placenta is going to attach to your uterus. And when it attaches, which should happen a day or two from transfer, it starts pouring out some of the hormone it makes, which is HCG, into your circulation. That's going to be very low levels for, a few days, right? But the smaller the surrogate is, and the more embryos that are pouring out HCG, the higher is going to be. So if you hear that a surrogate got pregnant with twins and she was testing 6 days after a transfer, you're going to see that. But just because she got one embryo transfer and she's 200 pounds and she's negative at day 6 or 7 doesn't mean she's not pregnant. And so when you pee, you're peeing out some of that hormone, and it should get out. And so as you guys know, it'll get darker as the days go. If you drank tons of water, it's going to be more dilute. If you use the urine that accumulated overnight, it's probably going to be more concentrated. So there's little things that are going to change it in the urine test. The blood test actually can quantify the amount of that hormone. And so we expect a doubling every 2 days. But I wouldn't say early on. I would say after 9 or 10 days of the transfer, you start seeing that, and definitely further into it. So, but a good pregnancy is when it goes up by 70% or 100% every 2 days. So it doesn't have to be completely doubling. When you start with a very low beta, it's a little bit concerning, but sometimes it results fine. But you start thinking, well, maybe did the embryo detach? Is it really going? So one thing is being pregnant, getting a positive. Another thing is the quality of the pregnancy. So your beta may be reflective. Like if your start beta is 13, that's fairly low, but it also depends what day they drew it, right? So if in one clinic they draw them on day 8, and in the other one, the day 12, you're comparing apples and oranges, because the levels are going to be very different. And so you do want to see, 1, you're pregnant, 2, how is it rising? And why is that important? Because if it's not rising properly, it could be a bad embryo that is about to miscarry or a failing pregnancy, but it could be an ectopic pregnancy. And I just had, end of last year, a lady that I transferred got pregnant with the first transfer, and it's an ectopic pregnancy. And so I catch these very early. I don't wait until I can see the baby waving at me in the tube. So I just basically had poorly rising beta HCG levels that maybe rose a little bit or stalled, plateaued. And that is very telling of that happening. And so when we catch it early, we can treat it with methotrexate. It's just an injection as opposed to having to do surgery. So again, just because it's a surrogate doesn't mean that you cannot have an ectopic. 1 out of 50 pregnancies is an ectopic. And so that's another thing that I pay attention to. And then the sonogram with a good machine like the ones we have, when your level is 1,000 transvaginally, we can see the pregnancy. In an old-fashioned machine, someone who's not that good, maybe 1,500. So that's why those levels are important, because if your level is above 1,000 or 1,500 and you're not able to see an intrauterine pregnancy, then it's very concerning that the pregnancy is elsewhere. And so for me, I don't care about the level that much. I bring everyone at 5 weeks and 5 days, because by then I should be able to see it. Because again, if you got transferred 2 embryos and you get pregnant with triplets, like your mom, for example, or twins, you're gonna have a much higher HCG level very early on, but biologically you won't be able to see that. And so but for me is I just want to make sure the pregnancy is in the right location. And so I just want to see that. I don't expect to see heartbeat and anything else. And so then after that, we worry more about the heartbeat. But then at that point, once I see clinically the pregnancy, so a clinical pregnancy means we saw it clinically with a sonogram. A biochemical pregnancy means that we never saw it, but we biochemically detected it, either by detecting the HCG, which is the chemical, in the urine or in the blood.
Okay.
Interesting.
Very
Okay.
Huh.
This is just so fascinating.
Very informative.
Very so informative. Yeah.
Good.
Does beta stand for anything? Or no? It's okay if you don't know. I'm just curious.
I've never been asked that question. Yes. I want to say that all these gonadotropins have alpha and beta subunits. And so I think it's just the beta subunit. And the beta HCG is the works attaches to the same receptor that LH attaches, and that's luteinizing hormone, which is the hormone that makes you ovulate. So
Okay.
that's why we use HCG to trigger either the egg donor or the intended parent to get those eggs out. So
if anybody's listening to this, Dr. Escobar, and they want to get in touch with your fertility clinic, how do they do that? Or your Instagram, or what? Give us some plugs.
So all my social media is Dr. Julian Escobar, and I have especially in Instagram, it allows you to have these like little circles at the top, the highlights, and so I try to organize it into either IVF or surrogacy or LGBT surrogacy, and so I think people can get more what they want. And just like you guys were talking about before, I'm starting now trying to go chronological in how the IVF process works. Obviously, I think that may be interesting for anyone, but I think especially as we transition into the embryo transfer, everything will be there. And one of the highlights is IVF, and if they want to skip all the IVF part, they can do it, and they just focus on the embryo transfer. I'll explain all the drugs, how they work, why we do what we do, all the tests. So that's that in my clinic. It's called Conceive Fertility Center, down to the point of what we do. And they can just Google us, the website's there, but social media seems to be kind of the way that that's how we connected, how people connect.
Exactly.
So,
no, I know. Thank you for getting back to me, because my goodness.
And I'm a sucker for surrogates. I love my surrogates, and I can tell you, you guys are just a patient, just like the intended parents are. And I think it's important for a clinic to treat people like that. It's not just, I know that there's the initial couple, the one that's probably covering the cost and engaged everyone, but it's important to get to know the surrogate well, also in the clinic.
Absolutely.
It's very important.
We're all humans. We're all people. We all are going to go on one of the most intimate journeys in your life.
Oh, that's what I was saying. How can you not spend the time getting to know? So I mean, like when you get to transfer time, so like if I transfer a surrogate, it's like, where are the intended parents?
Right.
Like, or like, why are you not FaceTiming or wanting pictures or sharing? It's like, what's going on here, you guys? Like you don't have to be obsessed. Like I went to all the OB appointments. People don't have to do that. But you want to have some healthy communication. I think it's just good for everyone. And sometimes intended parents are just too shy and they just don't know. They think it's intrusive. And like, you just need to have that little conversation,
Dr. Escobar, were you there for the birth of your twins and your partner? Were you both there in the room?
Yeah. Yes. There is, I'm going to tell you something. It's so weird you asked that. So it was a C-section. The hospital had just opened, and a new hospital. And this was the first case like that there. We had 25 people in the labor suite.
Wow.
And
whole teams,
yes, and it was a big deal. The two guys, I was a doctor, I used to deliver babies there. It's just like everyone and their mom was there. And so when in my mind, my partner was like very stressed out, and I was just very like my doctor brain.
Sure.
Kids came out all great, but when I got to hold my kid and I turned around, I looked at Molly strapped in, and I locked eyes with her, I started bawling. Like, so for me, was the eye contact with her. It's like, you made me a parent. That basically made the switch between I'm a physician and now I'm like a parent. I will never forget, her husband took the best picture of us where we're both holding a kid, and then in between us, you could see her there looking at the babies for the first time. I mean, my hairs are all standing. I have like goosebumps. It's just such a moment that only us can understand. You know what I mean? It's just
that's awesome.
Tiny little thing, but it's just that it happened because you were a parent when you made the embryos. You were a parent when she was pregnant. but it's almost like you don't get to be really kind of thinking until that kid, you know, you have that.
Have them. Oh,
And then
sure.
the NICU steals it away from you, you know?
Yeah, they do.
You're like,
We gotta weigh them. We gotta clean them. We gotta make sure they're okay. Yeah. Aw.
yes,
And
yeah.
on the flip side, from a surrogate's point of view, I mean, that's what makes us, that moment right there is what makes us want to keep doing it. Like that is like the ultimate euphoria. Like that is,
And it's hard to explain.
yeah.
It's
a high.
so
It's a natural high. Mm-hmm.
completely. It's like, I'll tell you, like when I was in delivering babies and let's say it's 3 a.m. and you're exhausted and you see that the guy cries, I was like, that's worth everything.
Yeah.
Because it's like you were here present in the moment. Like a lot of the time people are just somewhere else, you know, like it's just, and it's there's these little moments that mean it's a connection that just means a lot. So
Oh,
this has been lovely. Thank you so much for taking the time. I honestly, you're a busy guy, a busy physician.
No, super. I love this. I love that. I hope it helps people. You know, it's frankly, I think the clinics should be explaining all these to everyone, but it just gets busy and people just assume, you know. And like I said with the clinical clearance before, I do think it's a continuum. I think there's kind of the basic clearance, but it doesn't mean something cannot happen, and things change. It doesn't mean you didn't, you know, it's like anything. Like I had a very demanding intended parent, and she wrote in the contract, I had no idea, that the surrogate couldn't take anything, even Tylenol. Guess what? At 5 weeks and a half of pregnancy, she got COVID. She had a high fever. And I'm like, you're playing doctor, telling her not to take something. I said, what's going to happen? Like, I don't know. The brain of the kid is going to get affected if she continues having these fevers. But, you know, there needs to be a compromise. I mean, there's your ideal. Yeah. But so imagine if you are a surrogate and you just get COVID and fevers a month before or like right during your frozen embryo transfer, you may just have to take a little break. You know what I mean? And just like things can happen. Just like I told you, if I took a 6-month break just because she was going to drive her kids around, I think people just need, I know they're anxious, but they need to understand that you can't force situations, you know? I mean, so.
No, absolutely.
And just because there's a little something doesn't mean that you need to that the relationship cannot continue and you cannot move forward, you know. So that's what I mean. Like, it's like, what do you mean by clearance, you know? And so, but that's a term that was invented not by you guys or by us. That's really the attorneys have invented that. So
That's too bad.
That's like brand new information.
Yeah.
Oh my gosh. Well,
anyhow, you guys,
do you have any questions for us? I know, probably not. You're good. You're good.
I don't know how you guys do this, you know. So how many journeys did you and your mom do?
I had three.
Three. I did 3 and I'm starting my 4th.
And I had 6 babies for other people and she's had 3.
3, yeah.
That's amazing. You guys are amazing people. Completely amazing.
Thank you. Oh, so are you though. Without people like you, there would not be people like us.
Well, all of us, you know, and I think people do need to understand how special is that we can do that in the US.
Right.
Because people don't really understand that at the end of the day, it's a legal thing. In the rest of the world, if you cannot write in a document that this baby doesn't belong to you, if it comes out of you, it's your baby. And so you cannot do it, you know? And
that's crazy. I really hope Texas figures that out because that's crazy.
Texas has to wait, is Texas, if it comes out of you, it's your baby? Or is Texas pretty?
No, Texas is really great. Louisiana is like that. But right now, they, you know, like we used to be able to do all these things. And now, as I found out today, like if the embryo is not genetically related to the parent, then the judge may not determine that the parent is the intended parent is the parent.
Wow.
And that is something that you guys and the intended parents wouldn't wanna.
That's insane.
Yeah.
Right? You know, it's I don't know if this applies also to all the states. I don't know.
Yeah.
I mean, when I signed the contract, it was 25 pages long. I hear now they're 45 pages long.
Oh yeah, they're
If it seems that my contract was half of the contract about termination. You cannot terminate in Texas anymore. So why isn't it shorter? You know, I was like, well, why are you guys adding to it?
No.
And so it just gets very it just gets complicated. So
Absolutely.
yeah.
Well, thank you so much.
I know. Thank you so much. I know this took up so much of your time, so we really appreciate it.
no, thank you, ladies. But anything comes up, you let me know. But this has been wonderful. Take care.
so
Bye-bye. See
Thank
you guys.
you.
Take care. Have a
Bye-bye.
good night. See you. Bye-bye.
Thanks, you too.
See you. Bye-bye. Ciao. Bye-bye.
Bye. Oh my gosh.
Oh, I'm gonna tell you right now, Dr. Escobar, I was really nervous about interviewing you. Super nervous. But my gosh, what a
he was
phenomenal man.
so nice.
Phenomenal. He reminds me of Dr. Sahikian in a way, and that's what I was trying to tell him at the end.
Oh,
Like,
well, I couldn't relate to that, so I don't know.
oh, it's okay. Just because when an infertility doctor or fertility doctor treats the surrogate like she means something, like she's a big part of this, whereas sometimes you get lost with other aspects of surrogacy.
Sure.
The fertility doctor treats you like, oh no, and talks to you like you're a human and treats you like it makes the world of difference. And you know he does that. Just look how he talked to us.
I know.
I'm sure there's a ton of fertility doctors that do that. It's not just cut and dry, and it's not just a business. But this was
so crazy. I got to ask all the questions I always wanted to know, like, and not feel judged for asking them. Like, because when you go to a clinic, sometimes they're just like, get in, get out. Like, here's your meds, do what I tell you. Here's your schedule. See you in like a week or whatever. Like,
I love all the little stories you shared. That was so nice.
Oh my gosh, like
more real. Like, wow.
Just.
And I didn't really get to ask him if he did OBGYN, but he said
he just said that he did.
I'm getting there. He said he delivered a bunch of babies at that hospital, and then he went into so I just didn't get to ask at the beginning, but he already answered
it. He was very thorough.
Which was lovely.
Yeah, amazing. No, thank you so much.
Yes.
But he said where people can find him, right? On Instagram at Dr. Julian Escobar.
Yeah.
Okay. Perfect.
Julian Escobar. Yes.
If anybody has any questions or would like to share their story with us, what are you doing? Then please feel free to reach out to me on Instagram at Stop.Sit.Surrogate. And we are officially on YouTube. Thank you, Dr. Escobar, for being our first YouTube
podcast.
There we go. I don't even know what to say anymore. It's late. All right.
All right, everybody. This has been Stop.Sit.Surrogate with Kennedy and Ellen.
Bye, guys.